Good morning. I'd like to welcome everybody to the 28th annual Dr. Arnold Einhorn Lectureship. I'm going to give you a very brief background about why we're here today. 28 years ago, my partner in crime, who's pointer, but kind of there. To the left is Kathy Canal, who was one of the three chief residents when I was a senior fellow, and Evie, who is standing right behind me, it's exactly the same as in, and then Gina Capcella and two of my fellow residents, and we were probably conspiring to plan the first Arnold Einhorn lecture in 1992, which I think Evie and I probably planned more than anybody else, and I spent more time in the chief resident's office than doing any work that year. But we planned a party in celebration of Arnold Einhorn's legacy over the 13 years as leader here at Children's and many years before that in New York, which Joe will get into in a minute. But the purpose of the lecture was really to honor the legacy that Arnold left, and he left the legacy in his trainees. And what a lot of you don't know, especially the residents in this room, is that you are grandchildren or great-grandchildren of the Einhorn legacy, because all of you at some point have been trained by someone that Arnold influenced. And so this is probably the most important thing, or one of the most important things I get to do at Children's, is kind of be a part of this lectureship every year. And the really amazing thing is that the chief residents and the residents get to feel the history of Children's National that Arnold embodies in so many of the people that are sitting in this room. And it allows us to remember what a wonderful place this is, and in large part because what it was under Arnold. So with that, I'd like to bring up Joe Wright, who's one of the many former Einhorn lecturers who will talk a little bit more about Arnold and introduce our speaker.
Thank you, Craig. So it's now been 5 years since I was working full-time here at Children's, and so a few familiar faces, but many more new faces. I am, as Craig mentioned, a charter member of the Einhorn Society and was privileged to be the 26th Einhorn lecturer. And I am pleased to introduce the honoree. You have his bio in the program. I'll just read an excerpt here. In 1978, Dr. Einhorn joined the George Washington University School of Medicine as professor of pediatrics and chair of the Department of Pediatric Medicine and director of the Pediatric Residency Program here at Children's. In the 14 years that he led that residency program, it emerged as one of the premier and most sought-after programs in the country. His tenure at Children's National Medical Center was widely recognized for his strong advocacy of house staff education and their well-being, which I can personally attest to. I was president of the House Staff Association at the time, and Arnold took care of us. Arnold was born in Antwerp, educated in Belgium and France. During World War II, was ethnically cleansed from higher education, served in the French underground, came to New York City, the Bronx specifically, where he served as resident, chief resident, faculty at the Albert Einstein College of Medicine from 1954 to 1977. And Arnold is the one with the short white coat right there. And if you go to the website for the Albert Einstein College of Medicine, you'll see this representation. The Department of Pediatrics at Jacobi has a proud academic tradition that includes many luminaries, names that will be familiar to anybody who's in pediatrics: Harry Gordon, Henry Barnett, Abraham Rudolph, Louis Fraud, and Arnold Einhorn. As Craig mentioned, Arnold is most proud of his alumni. This is the legacy that he leaves, and here he is with his legendary slide sets. During his time in the Bronx, Arnold trained 3 presidents of the American Academy of Pediatrics. I doubt that there's a training program director in the United States who can claim this legacy: Judy Palfrey, Renee Jenkins, Bernard Dreyer. Upon moving to D.C., Arnold has been responsible, as Craig mentioned, for a litany of leaders in academic pediatrics. I won't go through the long list here, other than to say that one of the real gems of Arnold's genius is being able to put together residency programs where, just like a pluripotent stem cell, folks would be able to do whatever they wanted in terms of a career in pediatrics, and you see here just a representation of that. More recently, below the broken dotted line, as the Einhorn alumni cohort has matured, many of us are moving into C-suite leadership positions, including our speaker here today for health systems, including adult health. The Einhorn legacy is also international. Arnold has trained over 1,000 pediatric residents who are practicing all over the world, and we are not the only Einhorn lectureship here in Washington, D.C., but here in India, there is also an endowed Einhorn lectureship. That's right. You chose us. That's right. All right. It's great. It's really great for these young people to see you. And thank you, Arnold.
I had just missed it. You're big, much bigger than usually. I see you there. I see you all, and I remember them, and I love them, and it's a wonderful, wonderful thing. See the group of people who make such things that they do, and how they do it, and how they love it, and how have done all the people. I think that what they did, they are what they did. It isn't me. It's you people. You people, all. Correct?
He said it isn't him, it's all of you.
All right. Thank you. Okay. So, Arnold, we are honoree, Dr. Einhorn. Okay. We're gonna introduce our 28th Arnold Einhorn lecturer, Dr. Evaline Alessandrini. Dr. Alessandrini is a graduate of the Jefferson Medical College and completed her pediatric residency and chief residency here at Children's National. She completed an emergency medicine fellowship at the Children's Hospital of Philadelphia and also went on to complete a degree in clinical epidemiology at the Center for Clinical Epidemiology and Biostatistics at the University of Pennsylvania. And Dr. Alessandrini has contributed a tremendous amount of work to not just the field of pediatrics, broadly pediatric emergency medicine, but also in terms of the improvement science and healthcare delivery. And you see here some of the notable areas of her work in terms of practice standardization and registry development. Dr. Alessandrini is also a renowned educator, having been recognized at the Cincinnati, both at Children's Hospital of Philadelphia and at Cincinnati Children's Hospital for her expertise as an educator. arguably Evie's most profound impact on our field has been as a researcher and innovator, and has focused on the vulnerability of children at risk. Also, as a investigator within the Pediatric Emergency Care Applied Research Network, has helped to define the infrastructure through which healthcare services research is conducted in the pediatric emergency care arena. Evie's also always been a leader, always been a boss. And so this is Evie, I guess that's high school, before many of us knew her. But this was Evie, Evie was a resident and chief resident when I was a fellow. So a fellow in emergency medicine. By definition, we spend many times at the bedside of very sick children. And Evie clearly had the big hair going. Some of us were able to wear a shag then, but a little challenge now. But we had good times, and we learned a lot from each other. And privileged to have grown up with Evie in pediatric emergency medicine, published with Evie, and more importantly, Evie is now taking on a role breaking new ground as a pediatric leader in an adult health system. She is the Senior Vice President and Chief Medical Officer for the University of Cincinnati Health System, where she is responsible for the overall performance of clinical services within the University of Cincinnati Health Enterprise, focused on quality and safety. And this is a very, very unique role for a pediatrician to lead an adult system as Chief Medical Officer. I've taken a similar role about 6 months ago, so we have much to talk about, Evie. And we are just so proud of you and just so delighted that you're here as the 28th Arnold Einhorn. Get to your slide.
Oh, it's there?
Yeah, it's there. Yeah.
Excellent. Thank you, Chef. Good morning, everyone. I can't tell you how delighted I am to be here. Julie Bishop picked me up at the hotel. I found out the people mover was gone, and my entire memories of this place kind of crashed. But I'm so happy to be here. I'm gonna probably move relatively quickly through this, but I want to talk a little bit. My main goal today is to talk about integrating clinical research with improvement science, and when you do those things, how you can really accelerate improvement in patient outcomes. So I'll spend a little bit of time setting the stage. I really want to talk to you about 4 main areas that I think if we focus on those as improvers and researchers will really accelerate outcomes improvement. Talk a little bit about standardized care, applying theory, the importance of context, and capitalizing on experimental design. And perhaps if we have a couple minutes, I'd love to share with you what I've learned over the last 18 months as a systems leader in an adult healthcare system. Of course, I have to start out with gratitude. And principally my gratitude to Dr. Einhorn. And it was here that he taught me how to be an amazing and a master clinician. And I still say things that you taught me, like, if it ain't in the scalp, it ain't chicken pox. Told me that all the time. He also taught us, he gave me the opportunity to be a researcher in a very heavily clinical residency program at the time. Really taught me, as everyone mentioned, to think about the learners, and I have spent a lot of my time running a postdoctoral training program in improvement science during my 10 years at Cincinnati Children's. And so, I'm filled with gratitude. This is a photo from our 25-year residency we had a reunion here, and those are the three chief residents that were Dr. Einhorn's last residents, chief residents before he retired, and as Craig mentioned, really spent a lot of time having a really wonderful party. So on the far left is Gina Kupchella. I think you know the infamous Dr. E in the middle, and me and Kathy Canal. So just really quickly, a few other things to add about how Dr. Einhorn impacted my career as a pediatrician and as a healthcare, hopefully a leader. First, I am from a big, crazy Italian family, but he taught me the importance of family, and his relationship with Evaline really helped me to understand as I got married during our residency program that critical nature of that spouse and how that spouse is so important to you as a team in moving forward to contribute to life. And then we've got Monique and Nicole here, and daughters were everything, and dinners around the Einhorn table were really just a treat, and that was really important to me. I also am a Delaware. I was born in Delaware and went to Jefferson Medical College, and there were not a lot of pediatricians that came from Jefferson, and so Dr. E took a risk on me in taking me into his residency program, and I remember what he used to say is, yes, but are you a good person? And if you answered that question well, I think you maybe got into the residency program. I loved it here. I was here during the genesis of the weird Bear Without People, and I'm very happy to see that the bear has evolved to something brown and fuzzy that everyone appears to love more than when he first came to be. And I also was encouraged by Dr. E to make a change. And so when I was a chief and was applying for emergency medicine fellowship, my first choice was Children's Hospital of Philadelphia. And it was there that I went and got my clinical training in pediatric emergency medicine, did my master's in clinical epidemiology, had the opportunity to receive an NIH Career Development Award in Health Services Research. And I remember sitting in Dr. E's office with the red code pager. My suspicion is you don't carry those anymore, but the chief residents had the red code pager, and it was that pager that the email, or the text, here I go, I'm really dating myself. The pager went off, and it was the fellowship director from CHOP saying, you've been selected to participate in our fellowship training program, and he probably doesn't remember that, but I certainly do. I never thought I'd leave Philadelphia. This is Philadelphia. Spent 17 years there, my career in pediatric emergency medicine. Again, as I mentioned, I had a career development award from NIH. I was a health services researcher at the outset, and I really realized by the time 2002 came along that I needed to move from describing variation and gaps in care to actually closing gaps in care. And it was at that point in time that I moved from Philadelphia to Cincinnati. It was actually a teacher at Cincinnati, and went to Cincinnati Children's, where I had the great opportunity to learn improvement science and implementation science from some of the people that I think are the best anywhere in the world. And that's where I've actually spent the last 10 years of my career, which I kind of can't believe that I've been living in Cincinnati for 10 years, but I have. And over the last 18 months, I've really had the opportunity to take what I've learned and apply it in the adult health system. So I want to talk to you a little bit about what I've learned there and how I hope some of these lessons can help you to apply these things to your work every day, really mostly to improve outcomes for the patients that we serve. We really do have a tremendous responsibility and opportunity in what we do every single day. I just want to start with setting the stage, right? It really was in 2003 when Beth McGlynn published a study looking at the quality of healthcare delivered to adults in the U.S. We just didn't really know much about it holistically, right? And you only needed to remember one number, 55, because it was only 55% of the time that adults got the right acute, chronic, or preventive care, when they went to an outpatient setting. We did a little bit better in pediatrics. Rita Mangione-Smith replicated the methodologies of that study in 2007 and published in the New England Journal that kids got the right acute care 67% of the time, no emergency medicine. 53% of the time did they get the right chronic care, but only 41% of the time did they get the right preventative care. And how important is that to us as pediatricians? You may remember that this November, it will be the 20th anniversary of the IOM report to err is human. And we've made some great strides, but we certainly have a lot further to go. So as I alluded to before, it's been very, very important for me to think about how do we close those gaps? And that's really been where I've been focusing much of my career. I think it was interesting, spending a lot of time at Penn and in the Center for Clinical Epidemiology and Biostatistics, really focusing on my research career, that the Department of Health and Human Services defines research as knowledge generation, but it talks about it being independent of routine medical practice. And that just doesn't seem to be good enough, right? And what's another problem that we have is that it takes 17 years on average for only 14% of research to translate into practice. We've got to get better at this, right? We have got to implement findings that work, and I want to talk a little bit about that, because we also have research waste. We discover the same things over and over and over again. And imagine if we could actually implement things that work and then save those research dollars to really push innovation in the future. Steve Goodman, who is the editor-in-chief of Clinical Trials, he actually, I think, said it really best in an editorial that he wrote in Confessions of a Chagrined Trialist. Even if one knows what needs to happen at the bedside, one does not know at a system level how to achieve that in a safe, efficient, and sustainable way. And that's sort of what excites me about getting up and going to work every day, sort of trying to figure that out. So improvement science this is what really attracts me to improvement science, right? It's systematic, it's data guided. I get to use that research analytical part of my mind. But those activities are designed to bring about immediate positive changes in the delivery of healthcare. And that's what really makes me excited, to really change the way that we deliver services to people, to actually give them the health outcomes that they need. As we've matured in the clinical research arena, there are actually much more attributes of improvement science that are infiltrating the clinical research world. The experimental approach in improvement science is really multiple experimental cycles for quick learning and feedback, the Plan, Do, Study, Act, or Plan, Do, Check, Act cycle. And we change our interventions as studies progress. And that's occurring some now in adaptive trials. With design, we think about the reliability of the interventions and how they're going to sustain from the outset, right? You're really trying to get something that's going to have a lasting change, not something that will end when the grant ends. I've lived through that, created some really amazing interventions. The funding ends, and then people say, how are we going to support that? And it goes away, even though it's improved care. And then analysis is measuring over time, because all improvement is temporal, and we show our results graphically as data are collected. The scientific officer at the Institute for Healthcare Improvement, Don Goldman, who's really a brilliant person in this space, says the minute that you withhold data from people who are improving, it's when you change improvement to research. And so that's one important thing to remember about the difference between the two fields. So I'm going to transition into thinking about those four characteristics that I'd like to talk to you about, that I think if we take what's the best of clinical improvement and apply it to research, and what's really great about research and applying it to clinical improvement and integrating those things, is going to really help to accelerate our impact on outcomes. So first are the benefits of standardized care. This one, I think I probably have worn the most scars on over my 30 years in practicing medicine. Because what is the pushback that we get, right? Don't tell me how to practice cookbook medicine. I'm not going to practice cookbook medicine, right? But the goal is not cookbook medicine, right? The goal is never, ever to eliminate intended variation, right? Intended variation is an important part of effective patient-centered healthcare. It's the preferences of the patient. What we want to eliminate is unintended variation, because it's that unintended variation that actually results in waste in our system. It results in errors, and it doesn't allow us to get the best outcomes that we should be getting. The way that I teach the folks that I work with now is I always tell them variation should come from patients. Variation should not come from the physicians or other providers in the healthcare system. So I'll pick on Jim Chamberlain, my longtime 30-year colleague. If Jim and I were working in the emergency department together and a patient came in with asthma, there is a heck of a lot of great evidence-based care for asthma. And we should be delivering the exact same care to that patient in the emergency department. However, if two different patients with asthma came into the emergency department, we may not do the exact thing for them. One patient may be able to manage an inhaler better than a nebulizer. One patient's mother may say he vomits the steroids every single time, and I really know my child, I just need a shot, right? And so the variation comes from them. Variation doesn't come from us. But how do we hook the researchers in this case, right? So there are two main things, and this one I think is critically important to academic organizations, right? If you standardize care, you strengthen the ability to identify gaps in outcomes that require research and discovery. So this is a slide of outcomes in patients with inflammatory bowel disease. And the y-axis is the percent of inflammatory bowel disease patients who are in remission, and the x-axis is time. And you can see that between, I can even see this, 2007, about 50% of patients were in remission. And then once we hit about 2012, 2013, we were able to push that percent of patients in remission up to about 80%. We got stuck there. What happened there? Was there any amazing new discovery? No. It was just a group of providers, patients, healthcare systems coming together to apply best practice reliably between health systems and patients and families. That's a gigantic improvement in outcomes, right? 30% absolute improvement in outcomes. But then they got kind of stuck there. And for several years, that outcomes, the percent of patients in remission was around 80%. Well, now you know. Now we've got a gap. If our theoretical limit, and we want to get 100% of kids with IBD in remission, we need new discovery. We need something there to take it from 80% to 90% and to 100%. Researchers really get behind that. The second thing is the opportunity to increase statistical power and to decrease sample size. This is my first major attempt at scientifically using improvement science to improve care. And this is work I did at Cincinnati Children's starting in 2010 when we were looking at the median time it took for kids with cancer and Lyme's and fever and neutropenia to get their antibiotics. And it was pretty much chaos when I first started. You could see the red line there. It took about 140 minutes on average for kids to get their antibiotics. Some kids might have gotten it in 2 hours. Some kids might have gotten it in 4 hours. And over time, with implementing improvement sciences, we got it down to, this graph shows that it was about 40 minutes. Right now, it's about 26 minutes. It's the same. In 2019, same thing. Within minutes, we can say these kids are going to get their antibiotics in 26 minutes. We have so little variation now that if we intervene, we're going to pick it up like that, right? There isn't any noise in the background. So you're picking up the signal for the noise. And you're picking up the signal to because there is no noise. And so that is a huge opportunity to be able to write this type of information into your grant, your highly desirable system. Some people call it the reagent grade medical practice. And so the benefits of standardized care is just an incredibly important way to link those opportunities to improve outcomes. The second thing is the application of theory and improvement. And this is about understanding the how and not only the what. And so this is where research is really critically important in enhancing improvement, because there is a science of improvement. You know, there was perhaps a history about 20 years ago when people thought, well, maybe PDSA cycles are just a lot of people sitting around holding hands and singing Kumbaya and trying new things. But it actually really is a scientific method. And that scientific method is enhanced when we apply theory. So it really is, again, understanding that how, not just the what. And there is a difference between implicit and explicit theory, right? Implicit theory, it's your own personal constructions about a phenomenon, but explicit theory is reproducible and testable. You think a little bit about why do you have a recipe, right? If you're a really great cook, you might not need a recipe. Implicitly, you just know how to do it. But if you want to teach others how to do it and you want to get, reproducible results, it's probably good to actually have a recipe. And so that's sort of a little bit of a similarity with this. I want us to think together about two types of theory. We're not talking about grand or macro theory that's not amenable to testing. But every time you engage in improvement in improving care delivery systems, you want to make sure that you have a program theory. You should never really be doing improvement without that. And really that program theory links the mechanisms to the processes and the outcomes. And what you can do, most people will do that either in a fishbone diagram or a driver diagram or a logic model. When you want to publish your work, when you really want to have your work replicated, if you want to accelerate how quickly you can get the results in a system, there is a lot of opportunity to apply mid-range theory to your work. And I'll give you a couple of examples of that. So this is a picture of a key driver diagram. This is really the way that I learned how to do program theory at Cincinnati Children's. And this is the key driver diagram for the Evaline neutropenia project that I just showed you, where we were able to reduce the time to antibiotics from about 140 minutes down to about 30. And on the far left shows the actual SMART gain. So we were trying to get 90% of patients their antibiotics within 90 minutes of ED arrival when we first started. And you can see we obviously, thank goodness, exceeded that. But the key drivers are the what, right? So you actually have some theory in your head about, well, if I want to get antibiotics into kids quickly, what types of things do I need to be thinking of? And then to the furthest to the right are the interventions or the how that actually relate to those whats, right? So you can see on the top, we thought that we needed to rapidly identify and segment our eligible patients, right? So that was one of the what. And then to the right of that, you can see we developed some interventions or some of the how to figure out how to do that. Your driver diagram is a living and breathing document. Your theory is always robust at the outset and is usually informed by evidence and your literature search, but with time, as you actually get your hands dirty out there practicing and testing, sometimes you find out that you actually missed a few things. And so it's always good to keep track of this, almost like your laboratory notebook, and keep it dated and updated when you make changes to it. So really, it's very hard to do sustainable, reliable improvement without some type of program theory. However, there is an opportunity to really ramp it up and use some of these mid-range theories. I I'm going to just tell you really quickly the study that we did in the Evaline neutropenia patients is we used the Everett and Rogers diffusion of innovation theory. And this, if anyone's read the book, is a big old fat book, but this is an important book if you're an improver. And we worked on perceived attributes of innovation, right? Why should people want to change? We were building some electronic interventions within EPIC, which was the electronic health record system that we used at the time. And we wanted people to change their behaviors, and we wanted them to actually use these standard tools, which we would know would reliably identify our patients and make sure that they got the right care in a timely fashion. So we had to show them the relative advantage, right? We had to show them how what they would do in the new system would actually be better than what they had been doing in the past. We had to demonstrate compatibility, so we spent quite a bit of time doing workflow analyses to make sure that the intervention would fit in the workflow of a regular pediatric emergency physician or fellow in doing the work. Trialability was another really important characteristic. We tested this over and over in the EPIC playground for anybody who's used EPIC before, so that before it went live and you had to use it on a day-to-day basis, all the people had an opportunity in their daily work to try it out and to see and to contribute to the design. What I just really want to say is there are lots of theories out there that you can actually bring to your work, which actually makes you get results faster, and it helps with the sustainability. One that's very, very common is the theory of planned behavior. And so those are the two that we use the most, and I have found the most relevant to the work that I've done. Particularly one thing that's really fascinating about the theory of planned behavior is looking at subjective norms. And so these subjective norms are people I look up to believe that this behavior is a good thing to do. And so one thing that we've learned is that in a lot of the campaigning, getting those early adopters from the diffusion of innovation theory and those change agents that have credibility in the system to be on your team and to be a champion for the work is really a great way to help. So the take-home points about theory really is not only to describe the intervention that you chose, but really focus on how you expected it to work. And again, making sure that that program theory is always there, but consider that mid-range theory when planning work. How many people are familiar with context? It's a great, important thing. So context is everything. This is the Ebbinghaus illusion. Which orange circle appears larger? Right. The one on the right obviously looks larger, but it is not. They are exactly the same size. And it really just helps you to realize and inform us that it kind of is everything around you that really impacts our perceptions of things. So what is context? Here's some useful analogies. Gardening is a useful analogy, and John Overreis, a colleague from Sweden, made this analogy. So the seeds are the change context, right? What is the evidence-based care process or bundle that you want to implement? The change process itself is the improvement methodology that you might want to use, whether it's Lean or Six Sigma or the model for improvement. And context is everything that lives around it, right? It's your culture, your leadership, the resources, the training, and the motivation. But there are some issues, right? When we don't account for context, we find some oops, right? So, for example, if you did an intervention X in setting A and you got a great outcome and you were really excited, and maybe you even published it, but you really didn't publish your theory about how it worked, and you didn't really fully describe your intervention. Well, now setting D tries to replicate intervention X, and they get oops, it doesn't work, right? And so some examples of some oops or partial oops are the checklist for surgical safety or the impact of rapid response teams, on patient outcomes. And so really what we've got to do is think about context. Context in clinical care and improvement science is really different than context in a research study, right? So in a research study, typically you're choosing patients for inclusion in your research, and everything about them is the same except the intervention that you are testing, right? So it is sort of this nice, placid lake where wherever you take your sample, patients are pretty much the same other than the intervention. Well, what's a QI study like, right? It's like running down the rapids, right? Because the context of Children's National compared to Cincinnati Children's, compared to CHOP, they're all so different. And sometimes you don't realize it, right? One of my mentors said to me, Evie, fish don't know they live in water. And that's exactly it, right? How many people in this room have only ever practiced at this hospital? Right? Sometimes if you've only ever practiced at this hospital, you don't know anything else. I was telling Julie on the ride over here, when I moved from 17 years at CHOP to Cincinnati Children's, I could manage pretty much my administrative and academic work. It was really working clinically where I felt like somebody dropped me on another planet and I was an alien, right? Because things around you are so very different. But if that's the only place you've been, you actually don't know. We're just starting to really get our heads around context, and you can see in some earlier papers in Quality and Safety in Healthcare in 2005, the discussion is trying to get to tell you some things about context. Well, we had a knowledgeable and committed safety specialist. We had strong and passionate leadership, and all of these things we believe helped us to build a medication safety program that reduced adverse drug events. Even in 2010, with looking at neonatal central line-associated bloodstream infection. Well, what do we believe? Collaboration between state payers and providers, administrative support. So right now, as of 2019, there are lots of context conceptual models. I am not going to talk to you about all of these. There are a lot of them. But the important thing is when you are doing good scientific improvement, use one of these models, and it will help you to design your interventions in a way that are most likely to work. Now, personally, I like the one on the bottom left, which is called, I like it for lots of reasons. One is because Heather Paslin is my colleague, and she was the one who developed the model, but I also like it because it's called the music model. Got a nice name. It's the model for understanding success and quality. And the nice thing about this model is it looks at things like organizational factors, QI team factors, microsystem factors, where they're targeting an event that contextually make your interventions when you're improving care delivery work. And there are even, relations between them. And this table in the paper actually talks about how do you measure each of those. And there are references to say if we want to understand QI structure and QI teams, how can I actually measure those things? So if you look at the context literature so far, I chose 3 of the context models. One is called Paris, one is called CIFAR, and the other is music. And the rows in green are actually the characteristics of context that empirical evidence now exists to show that those things actually improve the success in quality improvement. So QI capability within the team, culture of your organization, and leadership in improvement and focus on outcomes are all things that make a difference. Resource availability and motivation, there's some emerging evidence, but then team decision-making processes or some of those external events or triggers have not yet been found empirically to be associated with improving quality intervention. You can see that that doesn't stop them from being in people's model, but certainly further research is needed to get there and understand that. So what are the take-home points for context, right? Think about context systematically and think about it at the beginning of your effort. Use a published model. It really doesn't matter which model. And then you should either design your QI effort to ensure the aspects of context are present. But sometimes you can't do that. You can't change your leadership. You can't snap your fingers and have capability built in your teams. So at least you can measure those things and understand them and the relationship between your work and the outcomes that you get. I'm going to wrap up with some experimental design. So who remembers the Pronovost study from 2006, right? Everybody remembers this study, and this was a great intervention to decrease catheter-associated bloodstream infection. And it was published in the New England Journal, and the results were shown in a table format like this. And they showed us that after 18 months, they were actually almost able to eliminate catheter-associated bloodstream infections there in the red box. You can see they were reporting out the number of bloodstream infections per 1,000 catheter days. And you can see here where they started. They started out at 2.7 infections per 1,000 lines, but they got that down to 0. So, remarkably, looks like data over time, just like in an improvement study, right? All improvement is temporal. Unfortunately, in 2006, in the New England Journal, they were not particularly used to reporting results using either statistical process control or run charts or anything like that. But if you looked at this study, what type of study was it, right? If you looked at evaluating the evidence, it wasn't a systematic review of RCTs. It wasn't a randomized controlled trial, right? It was a well-designed trial without randomization. And if you read the study, they called it a community cohort study. So everybody would say, oh boy, see, that's not great evidence. But if you actually read the editorial associated with that initial Pronovost paper, they said, this quasi-experimental study would warrant the designation of level C by the U.S. Preventative Services Task Force. Yet the real-world efficacy of the intervention is extraordinary. It's an A. And the story is compelling, and the cost relatively minor, and we can't accept variation in safety culture, and what if we could do this across all 6,000 hospitals? So since that time, since 2006, over the last 13 years, we've come a huge way. And I would like to advocate to you that if you are really interested in improving outcomes and doing implementation research in delivery system settings, there's a great opportunity for you to think about the different types of experimental designs that you can use to do exactly that. This chart was adopted from Don Berwick, who is the founder of the IHI, the Institute of Healthcare Improvement, and you can see he said on the left-hand side, if you're looking at simple linear cause and effect, traditional randomized controlled trials have been really the gold standard. And poor learning occurs in our case series or more anecdotal learning. But just like on the linear cause and effect side, if we're working, because we all work in fairly complex, nonlinear healthcare systems, that really strong learning can come using these different types of research studies, whether they're cluster randomized trials or time series trials, but there are lots of these that are going on right here in your backyard. This was the first large Rust cluster randomized trial that I did when I was at CHOP, and we did this in our primary care network. And what we did was we designed a clinical decision support tool to make sure that we were accurately diagnosing and treating otitis media. And we took 24 practices and we randomized them to either get the clinical decision support tool or to be a control practice. And then we had another factor there within that randomization. We then again randomized practices to either get feedback, audited feedback, or not. And you can see these are fairly complex studies, but they are real world, and the randomization occurs at the level of the practice, right? You can't randomize at the level of the patient or at the level of a physician because of contamination with the intervention. And this study was published in Pediatrics a few years back. And we actually did find that the practices that got the clinical decision support and the audit and feedback were the best at treating otitis media with first-line antibiotics. This was the study that I was telling you about. It was so slick, and it got great outcomes, and the pediatricians loved it, and it had photographs of bulging ears that you could actually, show to patients in the exam room. But then when the ARC study was over and the funding was over, there was nobody there to support the intervention, and it went away. So the good outcomes that we were getting, they ended. So it really is, how do we change that to make these things part of our regular work? Another study that we did here that Jim and I did together through the Pediatric Emergency Care Applied Research Network was really understanding which children with traumatic brain injury would not need imaging to make their diagnoses. And so we did this as an interrupted time series trial with concurrent controls, and you can see here that we baseline measured outcomes on patients, and then part of the team actually at time 0 got the intervention to risk segment patients for who did not need a CT scan, and then we measured the control group and did that standard of care so that we understood throughout the entire time if there were any secular trends that were impacting CT use for these kids. And we published this one in Pediatrics as well with some mixed results. That'll be a discussion for another day. Probably many of you know that. So, just about time. I want to make sure we have a little bit of time for questions. So looking forward. So I've had the great fortune to learn a lot and to spend a lot of time in 3 amazing children's hospitals with greatly different contexts and all completely invested in improving outcomes for children and assuring that the care that they provide is the best and never harms them. About 4 years ago, Michael Fisher, who's the Chief Executive Officer of Cincinnati Children, said, hey, there is an opening on the board of directors for the University of Cincinnati Health System, and they're looking for a physician with health system improvement. And would you like to be on their board? I recommend you that to be on the board. I said, sure, that sounds like a great growth opportunity. And was on that board for 3 years and watched a system with a gigantic amount of intellectual quotient, but really not the understanding of systems and improvement science to really get the outcomes for the patient that they really wanted to get. And so about 18 months ago, I literally walked across the street. Sometimes it feels like a moat between the children's hospital and the adult system, as probably many of you have experienced. But walked across the street to begin a foray into improving adult healthcare systems. And it is definitely, I would say, something that I think is dementia preventing. I'm using all new parts of my brain that I probably haven't used in a really long time. This is our new Gardner Neuroscience Institute. It literally just opened a week ago and is doing, taking care of using interprofessional teams to take care of patients with neurologic issues. But really, most of my time over the last 18 months has been building systems using all of those things that I just talked about today. Putting a structure of people together that puts patients and families at the top, that really defers to the expertise of those little red bubbles, which are the microsystems of people that are caring for patients. They are working together to implement evidence-based care. They are living the benefits of standardized care. And in 9 months, in our intensive care unit, bringing our 8 ICUs together, which, by the way, they never worked together ever, they have reduced catheter-associated urinary tract infections by 78%. And so now it's sort of this, what is possible? They are together, they're learning together, they're implementing evidence, they understand their context now. That is my job, to take all of those contextual factors that we know increase the likelihood of success of our improvement efforts. We are building a common language, if I can go the right way. Here are our teams. These are our ICU teams. You can see the happy people and the not happy people. This was in the beginning. Pretty much now everybody smiles. This is the central line associated bloodstream infection team. They all have now a common improvement language. They know UCH for UC health, understand continuously improve and habitual excellence. And this is what they're learning. They're learning science, they're learning language, they're learning methodology. They've got analysts sitting at the table with them. They've got performance improvement experts sitting at the table with them. And again, we're taking all of those things, standardizing care, using theory, understanding and building the context for them to actually get the results that they need to get. And now the part that I've just jumped into over the last 3 months is with our Senior VP and Chief Human Resources Officer, and we're building our talent management strategy and thinking all the way from acquiring our talent all the way through employee succession planning. How are we building the language of improvement and the science of improvement and what people need, what skills they need and what tools they need to have in their toolkit to use every day to get the outcomes that we're looking to get in our system. So it's been quite an exciting time, and I'm delighted that I had the opportunity to share it with you today. There may not be time for questions, but I'm happy. I'm going nowhere, so if anyone has any questions, I can answer. Yes, sir.
What are you finding are your major sources of resistance to your program?
That's a great question. So the question is, what am I finding the major sources of resistance? I think there's two things. I think understanding the benefit of standardized care is very, very challenging in an organization where there has not been that before. I think the second challenge is deference to the expertise of the people on the front line. Some of us were talking about this before, really recognizing that not only the frontline physicians, but the frontline pharmacists, nurses, the respiratory therapists, they actually know the best way to take care of patients. And so really my job is not to tell them what to do, but to be the backstage crew to make sure that they have what they need to get the work done. And so that's been a little bit of a change, right? Because everybody sort of works in their own silo, and bringing them together has been a challenge. I think we're cracking that nut now, as I told you about with the catheter-associated urinary tract infection team. But those are the great questions and what you think about every day when you wake up.
Well, I'd like to thank Evie for a fantastic talk, and we're continue this conversation in the 5th floor atrium, the research atrium, and so please join us there, and I'm sure we'll have a lot more discussion about some of the amazing things that Evie shared with us today. Thank you.